Hi again in part 2 decontamination with Dr. Dua Al-Gharabawi. We have talked in part 1 decontamination about skin decontamination, eye decontamination, and lung decontamination. In part 2, we will talk about gastrointestinal tract decontamination. Today, we will know the methods of GIT decontamination, how to choose the best method for your patient, and the steps of each method of them. How to do gastrointestinal tract decontamination. This can be done by removal of the unabsorbed poison from gastrointestinal tract by different methods, according to the site of the poison. If the poison is present in the upper gut, I can use emesis and gastric lavage. If it's in the lower gut, I can use whole bowel irrigation. I can also use another method, like inactivation of the poison in the gastrointestinal tract by using local antidotes. There are some points you have to think about when you decide to perform GIT decontamination. These points based on the ingested poison itself, delay time, which means the time passed since the ingestion of poison till presentation to the hospital, the presenting symptoms, and the predicted severity of poisoning. The first method of GIT decontamination is emesis. Emesis means to get rid of the poison from the stomach, and the only acceptable method to induce emesis is syrup of ipecac. All other methods used before are not acceptable now. People used to induce emesis through mechanical irritation of the posterior wall of the pharynx by fingers, which may lead to bleeding. Our grandmothers may use salt water to induce vomiting, which is very dangerous because it may lead to electrolyte disturbance, especially in children and old age. Also, apomorphine injection had been used, which acts centrally by stimulating the vomiting center, but it may lead to vicious circle of vomiting and dehydration. So all these methods are forbidden now, and the only acceptable method is syrup of ipecac to induce emesis. Syrup of ipecac is derived from dried root of Cephalus ipecacuana plant, but actually the pure extract derived from Cephalus ipecacuana plant is called tincture of ipecac, which is toxic. So we manipulate this tincture of ipecac by dilution and adding some substances to decrease its toxicity and produce the syrup of ipecac, which is used nowadays. Syrup of ipecac acts by two mechanisms: early vomiting through direct local irritation of gastric mucosa, and some of it is absorbed systemically and produce central stimulation of vomiting center, so it leads to late vomiting. That's why the dose of syrup of ipecac is given as initial dose and another repeated dose. I'll give the initial dose according to the age, and I'll wait for 30 minutes. If the patient doesn't vomit, I repeat the same dose for once, only one time. The adult dose will be about 30 milliliters, The children more than 2 years will take about 15 milliliters, and the children from 6 months to 2 years will take about 5 to 10 milliliters. The indications for using syrup of ipecac is ingestion of large amount of toxic agent, but under two conditions. The patient has to come early, within 30 minutes, to the emergency department and to be conscious. Contraindications to emesis can be divided into two parts. Contraindications related to the substance and contraindications related to patient. Contraindications related to substance like convulsions. If your patient gives a history of taking a convulsant agent and he is not in a convulsant attack, the induction of emesis may precipitate a convulsion attack, so it's contraindicated in it. In corrosives, the corrosive agent passed once and injured the GIT tract tissues and make them friable now. The emesis will re-expose these friable tissues to the corrosive agent again, which may lead to its perforation. Hydrocarbons, which are petroleum distillates like kerosene and gasoline, these are volatiles. During emesis, the patient may inhale the fumes of these substances, causing hydrocarbon pneumonitis, or he may aspirate his vomitus, leading to aspiration pneumonitis. We don't use emesis in sharp objects to avoid deep penetration and injury to the soft tissues. Also, it's not mandatory in case of non-toxic ingestion. The contraindications related to the patient include decreased conscious level, like in comatose patient, because he loses his airway protective reflexes and may go under aspiration pneumonitis. Also, in extremities of age, like old age, where the airway protective reflexes are diminished, and before 6 months, the airway protective reflexes are not well developed. Both these extremities of ages may suffer from aspiration pneumonitis. Excessive vomiting to empty the stomach. The patient may give a history of excessive vomiting, and he may give me another history like vomiting a substance or a secretion which is greenish yellow and bitter in taste. This is a bile secretion. This means that he emptied his stomach and started to vomit the bile secretion. All these group, like severe cardiovascular diseases, recent surgical intervention, bleeding disorders, and pregnancy, the patient suffers from one of these conditions, and I don't want to put my patient under the stress of emesis while he is suffering from one of these conditions. The second method of GIT decontamination is gastric lavage. The indications of gastric lavage include ingestion of life-threatening amount of toxin within 1 to 2 hours. Also, failure of emesis, or if there are contraindications for emesis. Contraindications of gastric lavage can be divided into absolute and relative contraindications. Absolute contraindications means never to use gastric lavage in these conditions, like inorganic corrosives, where these corrosive agents are strong and injure the tissues badly, making them friable and may lead to its perforation on administration of gastric lavage tube. Froth-producing substances like shampoo or liquid soaps. If I do gastric lavage with these conditions, this will induce froth formation, filling the whole GIT pathway and may lead the patient to aspiration pneumonitis. Patients with risk of perforation or hemorrhage, I can't use gastric lavage or administer the tube of gastric lavage in these patients. Relative contraindications to gastric lavage may include coma. Can I do gastric lavage in a comatose patient? Yes, after protecting his airway passage by cuffed endotracheal tube. Also, I can do gastric lavage in a convulsant patient after controlling convulsion with a specific treatment like diazepam. In petroleum distillates, I am afraid of aspiration pneumonitis, so I can protect the airway passage by cuffed endotracheal tube, then do gastric lavage. I can use gastric lavage not only for acute poisoning but also for chronic poisoning in certain conditions like morphine poisoning, where some of morphine will be re-excreted in the stomach and can be removed by gastric lavage. Usually, I use gastric lavage within 1 to 2 hours of toxicity, but I can use it for longer period, like 4 to 6 hours in certain conditions, like when toxin stays in the stomach for longer duration. In such cases, toxidromes like opioid and anticholinergic drugs, this decrease GIT motility and decrease gastric emptying, so the toxin will stay in the stomach for longer duration. Also, in condition of drugs that form drug concretions, these drugs like iron or salicylate, when they enter the humidity of the stomach, the tablets stick together, forming a large mass or bizarre, stays for longer duration in the stomach, so I can do gastric lavage after the 2 hours or 4 hours. Also, in salicylate may cause pyloric stenosis, so decreasing emptying of the stomach. I can use gastric lavage for patients with first degree of esophageal varices, but very gentle and only in the first degree where the the dilated vessels are not protruded into the esophageal lumen. The gastric lavage techniques will be discussed in details in the practical part, but there are two types of gastric lavage techniques. If the tube is introduced through mouth, it's called orogastric lavage, and if it's introduced through nose, it's called nasogastric lavage. We will take a hint about the nasogastric lavage technique. I will start the gastric lavage technique with the informed consent of my patient after explaining the full steps to him. Then I'll take a full history, especially the history about any accidents, recent trauma, injury, infection, operations or surgeries in the face, especially in the nose region. If there isn't, I'll start to check the nasal septum to avoid nasal septal deviation, check the two nostrils to choose the wider one, and prepare my tools including the nasogastric lavage tube and the syringe. I'll lubricate the lower end of the tube with water-soluble lubricant. Put my patient in a gastric lavage position, whether sniffing position or left-sided head-down position. While administering gently the nasogastric tube through nose, I'll ask my patient to swallow, because during swallowing, the epiglottis will close the larynx and trachea, preventing the tube from misdirection to the trachea, and the only its pathway will be to esophagus. Don't do gastric lavage after administration of the tube immediately, but you have to check that the gastric tube in its right position. Be sure first that the tube in the stomach Then fix the gastric tube by fixing taps and start gastric lavage. Complications of gastric lavage include mechanical injury, whether to nose, esophagus, or stomach, laryngospasm and cyanosis, irritation of the posterior wall of the pharynx and stimulation of gag reflex may lead to vomiting and aspiration pneumonitis. The stress condition of gastric lavage may lead to hypertension and tachycardia, but they are temporary conditions. They will be self-limited after the end of the lavage. They don't need any treatment. Sinus bradycardia can occur due to irritation of the vagus behind the posterior wall of the pharynx. Hyponatremia and hypothermia may occur in the two extremities of age, old age, and children because they are sensitive to any changes in electrolytes or temperature. This may occur when I use much water with low sodium content than saline. This may lead to hyponatremia, and hypothermia may occur if I used cold water in the winter to do gastric lavage for long period. Now we will talk about the inactivation of the poison in the gastrointestinal tract by using local antidotes. Local antidotes are substances that stop or counteract the poison or its effect in the gut. They have two types, chemical antidotes and physical antidotes. The chemical antidotes react chemically with the toxin and it changes its chemical nature by precipitating, oxidizing, or reducing it. However, they are not used nowadays, so we will not talk about them. On the other hand, the physical antidotes don't react chemically and don't change the chemical nature of the toxin, but react physically and they change its physical nature. They include demulcents, diluents, and adsorbents. Demulcents, they are substances that coat gastric mucosa, and so they decrease the contact between the toxic agent and the gastric mucosa, delaying the absorption of the toxin, such as milk, egg white, and olive oil. And as you noticed, they are substances present in our homes and can be used as an antidote in the first aid of toxicology. So they call them household antidotes. Diluents, from their name, they dilute the poisons like water and iced powder. However, water and neutralization are contraindicated to be used in case of acid or alkali corrosive because they increase the surface area of the stomach exposed to the corrosive agents and worse the condition. The ice powder is better to be used than water. Another example of physical antidotes is adsorbents. Adsorbents with D. And the most important example of adsorbents is activated charcoal. We all know that charcoal is produced by pyrolysis of organic materials. But to use it effectively in clinical toxicology, we have to activate it. The activation of charcoal is done through heating it in a high degrees, about 600 to 900 degrees centigrade, in the absence of air and in the presence of oxygen, steam, and acids. The advantages of this charcoal activation is to clean the surface of charcoal and to increase its adsorptive power. To know what is meant by increasing adsorptive power of activated charcoal, we have to know the mechanism of action of activated charcoal. Activated charcoal has different sized pores on its surface, small, large, and medium sized pores. These pores are the sites where toxins are adsorbed to activated charcoal with weak bond, forming what is called charcoal toxin complex. So the toxin will pass with charcoal toxin complex outside the body through stool, and this will prevent or at least decrease the GIT absorption of toxins. Therefore, activation of charcoal will increase the surface area of the pores, which will increase the amount of toxins adsorbed to activated charcoal. And this is what we mean by the increasing of adsorptive power of charcoal by its activation. We consider activated charcoal as very important in treatment of poisoned patients because it's safe, available, inexpensive, and easy to be used. It doesn't need special equipment or experienced personnel. Also, it's very effective in absorption of most of poisons. There are two forms of activated charcoal in the market, a powder form and a tablet form. In clinical toxicology, we depend on powder form. We don't use tablet form because to compress charcoal, forming these tablets, you decrease the size of the pores, decreasing the absorptive power of activated charcoal and making it ineffective. The single dose of activated charcoal to be effective will be charcoal to poison ratio 10 to 1, but it's not applicable. So another dose will be 1 gram per kg of activated charcoal will be mixed with about 90 milliliters of water or juice and administered orally. The slurry of activated charcoal has no odor and no taste, but has a black color and a sandy sensation in the mouth. This sandy sensation may stimulate nausea and vomiting for some people, and this is one of the complications of activated charcoal. Also, if my patient vomits with decreased gag reflex, he may suffer from aspiration pneumonitis. Sometimes activated charcoal is mixed with a cathartic like sorbitol. The administration of the mix of activated charcoal with the cathartics many times may make the patient suffer from diarrhea. Also, repeated administration of activated charcoal may cause constipation and abdominal pain. The most important complication or side effect of activated charcoal is the ability of activated charcoal to absorb oral medications if administered concurrently with activated charcoal. So, I have to separate between any oral medication and the dose of activated charcoal by about 2 hours. Let's talk about contraindications of activated charcoal, like drugs poorly adsorbed to activated charcoal, which are collected in a word called HICAM. H for heavy metals and hydrocarbons, I for inorganic corrosives and iron, C for cyanide, A for alcohol, and L for lithium. Activated charcoal is contraindicated in corrosives because of many reasons. One, most of corrosives, like inorganic corrosives, are not well adsorbed to activated charcoal, so it's ineffective treatment. Two, the sandy sensation of activated charcoal may induce vomiting, which will re-expose the friable tissues to the corrosive agent again, which may cause perforation, and also the patient may suffer from aspiration pneumonitis. The third cause, in corrosives, we need to do endoscope to determine the degree of burn and ulceration. However, the black color of activated charcoal will blacken the endoscopic field and mask the lesions. Finally, if the corrosive agents caused perforation in the gastrointestinal tract, whether in the esophagus or the stomach, the activated charcoal will pass through these perforations to the surroundings, causing mediastinitis or peritonitis. Also, activated charcoal is contraindicated in hydrocarbons because of, yes, hydrocarbons are not well absorbed to activated charcoal, and the sandy sensation of activated charcoal may induce vomiting, which will make the patient suffer from hydrocarbon pneumonitis or aspiration pneumonitis. Because the charcoal toxin complex passes through the intestinal tract outside the body through anus, the whole intestinal tract should be healthy. If there is any problem, I will not be able to use activated charcoal. These problems may be intestinal obstruction, perforation, hemorrhage, or paralytic ileus. Again, I can't use activated charcoal in a patient with disturbed conscious level except if I protected his airway passage by a cuffed endotracheal tube. At this time, I can administer gastric lavage tube and provide activated charcoal through the gastric lavage tube. So, disturbed conscious level is considered a relative contraindication for activated charcoal use. We have talked about single-dose activated charcoal, but we can use activated charcoal in repeated doses. That's what's called multiple doses activated charcoal. The idea of using activated charcoal in repeated doses is to fill most of the gut with the activated charcoal, to allow absorption of the large amount of toxins and getting rid of these toxins outside the body through feces. The dose of activated charcoal here will be 1 gram per kg repeated every 4 hours, or half gram per kg repeated every 2 hours. The doses of activated charcoal will be administered orally. I can use a cathartics with the doses of activated charcoal, but not with each dose, only once or twice per day. Multiple doses activated charcoal can be used in drugs still present in the gut for long duration, such as large preparations, for example, sustained release on enteric-coated preparations, or drug concretions. Do you remember them? Yes, the drugs that stick together when entering the humidity of the stomach and form a mass or bezoar. This mass will stay for long duration in the stomach, so I can use multiple doses activated charcoal in this condition. Also, I can use multiple dose activated charcoal in drugs decreasing GIT motility, such as in opioid and anticholinergic toxidromes. Another method of using multiple dose activated charcoal, not only for method of decontamination, but I can use it as a method of enhanced elimination to remove the toxin from the blood and get rid of it outside the body. The example for this method of enhanced elimination is gut dialysis. What is meant by gut dialysis? It means that some toxins have the criteria to passively diffuse from the blood through intestinal capillary wall and intestinal epithelial wall to be excreted in the lower gut. When these drugs pass from the blood to the lower gut, it will find the activated charcoal filling the gut and will react with the activated charcoal, forming charcoal toxin complex, and the body get rid of this toxin with feces. Here, I used multiple doses activated charcoal as a method of enhanced elimination because I remove the toxin from the blood, not before being absorbed. Another important indication for using multiple doses activated charcoal and is considered also one of the methods of enhanced elimination is to use repeated doses of activated charcoal in drugs with enterohepatic circulation. What is meant by enterohepatic circulation? Entero refers to the intestine and hepatic refers to the liver. So the toxin will be absorbed from the intestine, pass through portal vein to the liver, excreted through bile into the intestine again. So there is a cycle. The toxin pass with this cycle. Intestine, liver, bile, intestine. Again, from intestine to the liver, excreted through bile to the intestine again. This is enterohepatic circulation. Many drugs have this enterohepatic circulation, like morphine, thiophelin, digitalis, or whatever. The rule of repeating doses of activated charcoal is to fill the gut with activated charcoal. When the toxin is excreted with the bile to the intestine, it will be absorbed to activated charcoal, forming charcoal toxin complex, and will pass outside the body through feces. Now we will talk about another method of gastrointestinal tract decontamination, which is whole bowel irrigation. Whole bowel irrigation means to rapidly empty the gut within 4 to 6 hours by washing the gut with polyethylene glycol. Here, I don't use as usual tap water or saline, but I use a substance called polyethylene glycol. This substance is characterized by high molecular weight, so it's non-absorbable and electrolytically balanced. I administer the gastric lavage tube and then provide about 1.5 to 2 liters per hour in adult patients and half liter per hour in children. Continue administration of the polyethylene glycol until the rectal effluent is clear. But take care, if you administered about 6 to 8 liters in adult patient without any rectal effluent, stop and postpone the process until there is rectal effluent to avoid complications. Whole bowel irrigation is not usually used, but it's indicated in case of huge toxic ingestion of drugs poorly absorbed to activated charcoal, or in case of huge toxic ingestion of sustained release or enteric coated preparations, also in case of ingestion of drug-filled packets or condoms. What you see in this abdominal X-ray is not ingestion of capsules, but it's a condoms filled with illegal drugs. The smugglers fill the condom with illegal drugs and wrap and seal them well, then swallow them. In this condition, I can't use emesis, gastric lavage, or activated charcoal to get rid of these drug-filled packets or condoms. I only can remove them through whole bowel irrigation or surgical removal. Contraindications for whole bowel irrigation include any problem in the intestinal tract, like intestinal obstruction, perforation, paralytic ileus, or gastrointestinal hemorrhage. Also, whole bowel irrigation is contraindicated in case of comatose patient, except if I protected his airway passage by cuffed endotracheal tube. The same in case of convulsions. I have to control convulsions first with its treatment, then do whole bowel irrigation. Intractable vomiting and hemodynamic instability are also contraindications for whole bowel irrigation. The complications of whole bowel irrigation include nausea, vomiting, regurgitation and pulmonary aspiration, and bloating with abdominal cramps. Thank you.